One of the most interesting side effects of DORAs is this, sleep paralysis. So if you understand why that happens, you'll understand almost everything important about this drug class. Today we're going to talk about how dual orexin receptor antagonists work, who benefits the most, and why you might end up disappointed by them. Because after prescribing these medications and looking at the literature, I have come to this conclusion. I think many clinicians are disappointed with DORAs because they're expecting a wake-reducing medication to solve a circadian problem or a sleep apnea problem or a lifestyle problem. So we're going to look at what DORAs treat, who they're best for, which one I choose in different clinical situations, and why some patients who seem like perfect candidates end up getting not that much benefit. If you're new here, I'm Dr. Nishi Bhopal. I'm a board-certified sleep medicine physician and psychiatrist. This channel is for you, the healthcare practitioner who wants to learn more about clinical, integrative approaches to sleep medicine. Every video is also eligible for CME. You can click the Learner Plus link below this video to claim your CME or CE credits for today. Okay, so before we talk about the efficacy of DORAs, let's start with the mechanism. DORA stands for Dual Orexin Receptor Antagonist. The three FDA-approved agents are suvorexant, or Belsomra, lemborexant, or Dayvigo, and daridorexant, or Quviviq. To understand how they work, you need to understand orexin. So orexin is also known as hypocretin. It's one of the brain's major wake-promoting neurotransmitters. You can think of it as your brain's accelerator pedal. Orexin neurons in the lateral hypothalamus stimulate wake-promoting centers throughout the brain and maintain wakefulness. DORAs block both orexin receptor subtypes, OX1R and OX2R, and they reduce the wake signal. So this is where they're fundamentally different from benzodiazepines and Z drugs or Z drugs. While traditional hypnotics put the brakes on the entire car, DORAs take your foot off the gas. Now this distinction has real clinical consequences, and here's why. DORAs are not forcing sleep or sedation, they're reducing wakefulness. So sleep architecture tends to be a bit better preserved with these drugs. Many patients might describe it as feeling more natural than a traditional hypnotic. Now the three FDA-approved drugs do have different half-lives. Suvorexant has a half-life of about 12 hours, lemborexant has a half-life of about 18 hours, and daridorexant has a half-life of about 8 hours. One of the more common questions your patient might ask is, well, what time should I take it? All three are recommended to take within about 30 minutes of bedtime, with at least 7 hours before they plan to wake up. And an important clinical pearl to remember is about food. So why is that? Well, taking a DORA with a high-fat meal can delay absorption by about 1 to 1.5 hours, meaning it may take longer to kick in. Okay, so back to sleep paralysis. Why does this happen? Well, orexin deficiency is the underlying pathophysiology of narcolepsy type 1. And what do we see in narcolepsy? You see sleep paralysis. We also see hypnagogic hallucinations, REM intrusion phenomena. So when we pharmacologically reduce orexin signaling, we occasionally see similar symptoms and side effects. The data backs this up. There's a 3.4 times higher risk of sleep paralysis with DORAs versus placebo, and there's a 2 times higher risk of excessive daytime sleepiness with DORAs compared to placebo. So these medications are targeting wakefulness, and that's exactly where many clinicians get tripped up. Okay, so let's talk about this a little bit more, because if you are prescribing these medications in your practice, or if you see patients who are taking them, you need to know about this. So let me tell you about my patient. We'll call him John. He was in his 30s. He was taking Belsomra or suvorexant, and his chief complaint was, well, it doesn't really work for me. And so if you had just stopped right there with that patient, you might have concluded, well, that drug didn't work for him, so let's try a different drug. But when you look at the bigger picture, the story becomes very different. It turned out John was drinking alcohol most nights, he was using cannabis, his sleep schedule was all over the place, and he likely had something that is often missed when it comes to insomnia treatment, and that was untreated obstructive sleep apnea. So at that point, the question becomes, well, what exactly are we asking the medication to fix? A DORA can reduce wakefulness, but here's what it cannot do. It cannot fix alcohol-induced sleep fragmentation. It cannot correct circadian disruption. It cannot treat sleep apnea. It cannot compensate for a nervous system that's activated for 18 hours a day. Most insomnia medications fail because the diagnosis was wrong, not because the medication was ineffective. This is exactly the type of case that we dive into inside the Clinical Sleep Kit program for clinicians. And when I evaluate insomnia, I like to think about 3 major drivers. These are like 3 legs of a stool. They are your circadian rhythm, sleep drive, and hyperarousal. and I call this the CSH framework. DORAs theoretically target one of those drivers, which is hyperarousal, but to be precise, DORAs reduce the wake drive at the cortical level. The evidence that they directly reduce physiological hyperarousal, like cortisol and sympathetic tone, is still limited. So think of it this way. If you have been driving 90 miles an hour all day in your car, you don't suddenly pull into the garage and come to a complete stop and park. You have to downshift, you have to slow down, you transition and slowly come to a full stop. Sleep is like this. Good sleep starts during the day, not when your head hits the pillow. So a DORA can help you take your foot off the gas, but it cannot park the car for you. And if you're a clinician who wants a more systematic framework for evaluating and treating insomnia, I've got a free sleep mini course for clinicians. It covers an assessment framework and how to build a treatment plan that works long-term, not just while the patient is taking medication. The link is in the description below. It's free. It's for those of you in clinical practice. You can get it at intrabalance.com/doctors. Okay, so let's talk about 3 patient populations who tend to benefit the most from DORAs. Number 1 is older adults, people over 65, and this is probably the strongest use case. Benzodiazepines and Z drugs, or Z drugs, I'm Canadian, so I say Z, they are on the AGS, the American Geriatric Society, Beers criteria avoidance list for older adults because of falls, cognitive impairment, and delirium. DORAs are not on that list of drugs to avoid. In the Sunrise 1 trial, where they looked at over 1,000 adults aged 55 and up, lemborexant outperformed both placebo and zolpidem ER on sleep onset, maintenance, and second half of the night wakefulness without impairing postural stability, next morning memory, or driving performance. And there's something else interesting for clinicians that you should know, which is that early data suggests that DORAs may have neuroprotective rather than neurotoxic effects. A randomized trial in 38 cognitively unimpaired adults found suvorexant 20 milligrams acutely decreased CSF phospho-tau by roughly 10 to 15% and amyloid beta by 10 to 20%. Now, this is still investigational. That was a tiny study, but it's the opposite direction from what we worry about with chronic benzo use. So I'll be really curious to see what comes out of this research. The second patient population that tends to benefit most from DORAs is patients with comorbid insomnia and OSA, also known as COMISA. Now, there is just moderate evidence for using DORAs in this population. Now, did you know this? About 30 to 35% of your insomnia patients also have obstructive sleep apnea. DORAs don't worsen apnea severity or oxygen saturation. For COMISA patients, this is a very important clinical distinction from GABAergic drugs. Now, the third patient population who tends to benefit the most from DORAs is substance use disorders. There's moderate evidence in this patient population as well. Patients with substance use disorders have historically had very limited safe pharmacotherapy options. Now, DORAs are also Schedule 4, which is the same as things like zolpidem or benzodiazepines, but with a lower abuse potential. Now, in opioid use disorders specifically, the orexin system's role in reward and craving pathways may make DORAs therapeutic beyond just the sleep effects. That's another area of research to be on the lookout for. So are DORAs safe to use long-term? Up to 12 months continuously is thought to be safe, but there's no randomized controlled trial data beyond 12 months at the time of recording this video. DORAs are thought not to have the following issues: no tolerance, no physical dependence, or no withdrawal, according to current research. The New England Journal of Medicine recommends that for patients who do require ongoing pharmacotherapy, intermittent dosing of about 2 to 4 nights per week is a reasonable long-term strategy. 12-month data on daridorexant showed sustained efficacy without dose escalation, and a 7-day placebo runout showed no withdrawal symptoms and no rebound insomnia. So that's a different conversation compared to the Z drugs or Z drugs and other GABAergic agents. With all of that said, after years of teaching clinicians in my online programs and in other lectures, there are 2 things that clinicians often forget about, but are vital to treating insomnia successfully. The first thing is this: insomnia itself drives medication seeking. Chronic insomnia is a relapsing condition. So when patients stop any effective treatment, the underlying insomnia often returns. Not necessarily as rebound, but as the natural course of the condition. Plus, normal sleep, even without insomnia, can fluctuate by 1 to 2 hours a night. So patients might interpret that as a return of insomnia symptoms or as a sign that they need medication, when it's actually normal normal fluctuations and to be expected. The second thing is this: conditioned sleep anxiety. Patients with insomnia often developed conditioned arousal around the sleep environment. An effective medication can become a safety signal, so patients feel like they can't sleep without it, even though no pharmacological dependence exists. This is a cognitive behavioral phenomenon, not a drug effect, and it's best addressed through CBT-I, which is cognitive behavioral therapy for insomnia. The clinician who is experienced in treating insomnia implements these 4 strategies to minimize psychological dependence. Strategy number 1 is to pair it with CBT-I, which is cognitive behavioral therapy for insomnia. That's the first-line gold standard treatment. The New England Journal of Medicine review recommends combining pharmacotherapy with CBT-I because we need to address the maladaptive beliefs and the conditioned arousal that might underlie that psychological dependence on any sleep medication. Strategy number 2 is to consider using intermittent dosing. Again, that recommendation from the New England Journal of Medicine review, because we want to help that patient with chronic insomnia develop their sleep confidence, or their confidence in their ability to sleep without medication long term. Strategy number 3 is to set expectations early. You want to counsel patients that the medication treats symptoms, does not treat the underlying cause or causes of their insomnia, and that CBT-I is the first-line most effective treatment we have for insomnia, and addressing the underlying contributing factors will lead to long-term success, and that is much easier than they might think, or even that you might think as the clinician. Strategy number 4 is to leverage the absence of rebound with these medications. The fact that DORAs can be stopped abruptly without rebound insomnia is a powerful counseling tool, so patients can stop it without a fear of a withdrawal-driven bad night, which is the experience that most strongly reinforces psychological dependence with other sleeping pills. So of the 3 FDA-approved DORAs, which one is the best one? Well, my short answer is patient selection matters far more than the specific medication. But there are some important nuances worth knowing. Suvorexant is your veteran. It's got the longest track record and the most clinical experience behind it. Lemborexant has strongest data for sleep onset, and it has performed particularly well in studies in older adults. And daridorexant is most useful when next day sedation is a concern, because it's the only one of the 3 to show improvement in daytime functioning in phase 3 trials. Now, before you prescribe any of these drugs, make sure you check this. All 3 of them are CYP3A4 substrates, so you need to do a medication reconciliation at every visit to check for drug interactions. And there are 3 populations that require a dosing adjustment with more conservative dosing. Specifically for suvorexant, the levels are higher in women and people with obesity, so you want to use lower doses in those 2 populations. And you want to use lower dosing in patients with moderate hepatic impairment. These drugs are not recommended in patients who have severe hepatic impairment. And if you are prescribing these medications, make sure you do this from the very beginning. Counsel patients on sleep paralysis before it happens, because it can be alarming if they're not expecting it. And at follow-up, ask specifically about these side effects: sleep paralysis, excessive daytime sleepiness, vivid dreams, nightmares, and hypnagogic hallucinations. Complex sleep behaviors like sleepwalking, sleep eating, and so on carry an FDA class warning. So if those adverse effects occur, discontinue the drug immediately. And you also want to monitor mood in patients with pre-existing depression. All right, so here's your suggested clinical protocol. At initiation, set expectations. Counsel patients on narcolepsy-like symptoms and side effects and complex sleep behaviors. Get a baseline ISI, which is the Insomnia Severity Index. I have a whole separate video on that. You can check that out after this video. And consider getting a baseline sleep diary. At 2 to 4 weeks, assess efficacy with that sleep diary and follow up ISI, and screen for side effects and tolerability. Every 6 months, if you're using it longer term, reassess whether that medication is still needed. From the get-go, have the CBT-I conversation. Evaluate those underlying factors keeping the patient stuck in the cycle of insomnia. And here's what to know if you are stopping or discontinuing the DORA. Generally, no taper process is required. It is thought that DORAs can be discontinued abruptly. Now, again, some return of those insomnia symptoms is expected. Sleep naturally fluctuates, and that's also the natural course of insomnia disorder. It's not necessarily a sign of withdrawal. And those are 2 very different things clinically, and important for the patient sitting in front of you to understand. Now, experienced clinicians are able to see the bigger picture of sleep beyond medications. And this is what it looks like in clinical practice. So Ellen was a patient in our effortless sleep coaching program for adults. And we get loads of patients who join because they eventually find that sleeping pills just don't work for them consistently. And they're not getting the relief that they want. And Ellen was taking QVivic or daridorexant, and it kind of helped, but only modestly. So why did it not work as well as she had hoped? Well, she was terrified that she would not be able to sleep without it. She ended up developing a phobia around being awake at night, and a phobia of having insomnia itself. So she was losing sleep over her sleep. And we were asking an anti-wake medication like a DORA to solve a deeper problem with her relationship with sleep. Medications don't resolve the perpetuating factors that keep patients stuck in the vicious cycle of insomnia. The medication itself isn't failing, it's just being asked to do something that it was never designed to do. This is why I always encourage clinicians to think beyond the prescription. The DORA is not the treatment plan. It is part of the treatment plan. For example, if you have a highly motivated 45-year-old executive with chronic insomnia, I'm thinking about hyperarousal, circadian factors, sleep drive, behavioral treatment, medical issues, lifestyle, the patient's relationship with sleep. I'm thinking about all of these things at once. But if you have an 82-year-old with dementia and fragmented sleep, that's a very different clinical conversation. So context matters. Patient selection matters. Understanding what's going on with that patient's sleep, why they're not sleeping, what the underlying drivers are, matters. This type of sophistication and nuance with sleep treatment is exactly what clinicians develop in the CSK or Clinical Sleep Kit training program for clinicians. Because when you can help your patients achieve restorative, refreshing sleep, it changes their whole life. So what's my overall take on DORAs? Well, they are a useful drug class. They're safer than many of the alternatives that we have historically relied upon. And they have a meaningful role in older adults, COMISA, and substance use disorders. But the clinicians who see the best outcomes are the ones who understand what they're actually treating and what they're not. Once you understand the actual drivers of that patient's insomnia, DORAs become much easier to use and much easier to predict who will benefit from them. If this information was helpful for you, click the like button below and I'll see you in the next video.